Good evening, everyone, on this wonderful Wednesday. I'm Tonya Kidd. I'm the program manager here at Team Phenomenal Hope. I want to thank each of you for joining us this evening for our third and final pH Awareness Month webinar. If you missed our social determinants of health in pH last month or our informed patient tell-all in September, please scan the QR code on your screen to view the recording of these webinars. A little background about Team PH. Team Phenomenal Hope is a nonprofit organization founded in 2012 to raise awareness of pulmonary hypertension. Our mission is to provide patient-centered programs and educational resources for those living with PH and to improve their life, bring them out of isolation, and contribute research dollars to locate better treatments and a cure. And tonight, of course, this would not be possible without our wonderful sponsors. We would like to thank Johnson & Johnson, CVS, Carol's, and Bayer. And first, before we begin, there are a few announcements. To learn more about our many programs on your screen there, please scan the QR code or visit our website, teamph.org/programs. One program I would like to highlight is our new Phenomenal Connections peer-to-peer pilot program. This is a free program that connects trained volunteer peer supporters living with PH with other PH patients looking for or needing support after receiving a diagnosis. For more information, you can visit teamph/phconnect.org or scan the QR code right there on your screen. Also visit our PH educational resource website, learnlivebreathe.org, to learn more about the latest research, medications, treatments, and how to navigate and manage PH. This is a phenomenal resource for both patients and caregivers. So moving along, we will have a Q&A session at the end of this presentation. You can use your Q&A button at the bottom of your screen to input your questions. When you click, a box will pop up. You can type your questions there. And tonight I have Kira Kronk. She's volunteered to assist me tonight with the Q&A session. Kira is a patient advocate who has been a great asset to us here at Team PH. She assists with the bi-monthly support groups and much more. And lastly, before logging out of the webinar this evening, even if you have to log out a little earlier, there will be a pop-up survey. It would be greatly appreciated if you could please take a minute to complete the survey and share your feedback and thoughts on tonight's webinar. Tonight's webinar is packed with great information and will be presented by several of Team PH great friends and medical professionals in the field of PH. First up, I would like to introduce you to Dr. John Kingrey, Medical Director at Interest Health, Pulmonary Hypertension Center, Oklahoma City, Oklahoma. His topic tonight will be pulmonary hypertension, interstitial lung disease, also known as PH-ILD. Thank you, Dr. Kingrey, for being here tonight. It's all yours.
Yeah, thank you, Tonya. Well, I am honored to be able to talk to you for a few minutes this evening about one of the subtypes of pulmonary hypertension that is something that's really, really common. And for those of you who may be listening who have interstitial lung disease, this will be perhaps of particular interest to you. And for those of you who may have another form of pulmonary hypertension, likely pulmonary arterial hypertension, you may think, well, this may not apply. But I think that there are enough correlations that it'll be worth at least learning a little bit about. So first of all, what is interstitial lung disease and why do we care? Okay, so ILD is what we refer to interstitial lung disease as, is any of a number of lung disorders that cause inflammation and or scarring in the lungs. And the interstitium is a major portion of the lung tissue that provides structure and order. So there are different components to the lungs, but the interstitium, kind of think of it almost as like the framework that kind of holds it up, so to speak. Okay, so I have pulled up for you all 2 CAT scans. Okay, and what you kind of need to orient yourself to these CAT scans, if you've never looked at this with your provider before, is that you're kind of looking at your chest cut like a ham bone, okay? So it's cutting through you, and kind of in this view right here, we're cutting in the heart, okay? We're at the level of the heart, and we're kind of cutting you open. So you're looking up from your feet. And so what is on the, what appears to be on the left to you is actually the right lung, and what appears to be on the right is actually the left lung. And as it relates to the interstitium, I've pulled up a CAT scan that really is pretty normal, okay? Doesn't have any abnormal features of inflammation or scarring. You'll see some of these white things. This big glob in the middle is the heart, okay? So these white structures are actually blood vessels, okay? You can see on the left, looks pretty normal if you're not oriented, but I put an abnormal CAT scan on the right to help you understand at about the same level of the lung, to help you understand what interstitial lung disease looks like, one form of interstitial lung disease, okay? Lots of different things that are embedded under the umbrella of interstitial lung disease, but you can see all of this kind of, I call it schmutz, all right, towards the outer edges of the lungs, okay, in particular, but you can see it here. All this white stuff, these are not blood vessels. You shouldn't be able to see blood vessels out this far. This is all thickening of the lung, okay? And that thickening causes problems. And what you're seeing here is predominantly scar, okay? So again, one form of interstitial lung disease that is a form of pulmonary fibrosis, okay? So why do we care about this, especially in the pulmonary hypertension world? Well, first of all, interstitial lung disease can give you shortness of breath. It almost always does. It leads to cough, okay? And it is will cause your oxygen levels to go low, and it can cause you to be fatigued, among other things, okay? But we also care because it can cause pulmonary hypertension, all right? And for those of you who have pulmonary hypertension not from interstitial lung disease, you know that it can cause shortness of breath and low oxygen and fatigue by itself. And then you throw in a disease of the lung on top of this, and now you have a situation where you can have, really, it's insult to injury, okay? So if you have interstitial lung disease, how likely are you to get pulmonary hypertension? Well, that's kind of a complicated answer because it depends on what kind of interstitial lung disease you have, how bad it is, and kind of what your lung function looks like. But you have anywhere from about a 20 to a 70% chance of having PH. And people who have interstitial lung disease that are approaching the need for lung transplantation, for example, are around that 70% risk of having pulmonary hypertension, and as high as even in the 80s, depending on the studies you look at. Those are not small percentages. There's a really, really good chance that if someone has interstitial lung disease, they could develop pulmonary hypertension as a result. And so patients with PH-ILD, which is our way of saying that people have pulmonary hypertension because of the ILD, or the ILD caused it, okay, typically do significantly worse than patients who have just ILD with no pulmonary hypertension. It affects both quality of life and actually survival. And the worse the pulmonary hypertension is, usually the worse a patient is going to do. And I think that makes sense. And I share that not to scare you, but to help you understand that this really matters. So why do you get PH from ILD? I get asked that question a lot. One of the things is that on this cartoon here, you can see as blood is coming into the gas exchange units, or where the actual functional part of the lung where you exchange oxygen, okay, when your oxygen levels are normal, those blood vessels are nice and wide open. But when you expose the lung your body to environments where oxygen goes low, okay, and for any reason, but in this case, it would be because you have that fibrosis and scarring that doesn't allow normal gas exchange or normal oxygen, those blood vessels you can see will start to narrow, okay? It's the body's actually reflexive response. It's a built-in mechanism. And this is also, by the way, for those of you who have pulmonary arterial hypertension and who have low oxygen, not everybody with PAH does, but many of you do, this is why your doctor is so interested in making sure that you wear your oxygen. Because even if you don't have a lung disease, you are still going to get that narrowing, or we call it vasoconstriction, meaning that the blood vessels narrow, okay, because of low oxygen tension or low oxygen environment. And that's going to make your PAH even worse. All right. So oxygen, even if you don't feel it, even if you're one of those people that you have a SAT of 85% and you feel totally fine, your lungs are feeling it. Okay. And this diagram is not intended for you to study, but to understand that in settings of chronic hypoxia or low levels of oxygen in the blood, which happen in PH-ILD, there's a whole lot of bad things that happen to the blood vessels in the lungs, okay, that lead to chronic changes and that can worsen pulmonary hypertension over time. Now, for those of you who may be a little bit more scientifically oriented, I only throw this in here just so that you can kind of visualize what happens in these tiny little pulmonary arteries. And remember, you have hundreds of thousands of these tiny little pulmonary arteries that are microscopic. And if you look at them under the microscope, okay, this first and third image, there's kind of, they're different techniques, but it kind of shows you a nice thin wall to that artery. And what happens in a patient with pulmonary hypertension with IPF, for example, or idiopathic pulmonary fibrosis, a form of ILD, that wall gets thickened, okay? And even in areas of the lung with people who have IPF or other forms of interstitial lung disease, even when there's not lung damage, that in the upper parts of your lung, for example, if you have IPF, you still get that narrowing of the arteries, all right? That can still happen even when the lung tissue surrounding it is normal. So it's just to help you kind of get a visual of this actually is really something that's affecting the blood vessels of your lung and your heart. So probably the most important question for you all is, okay, what can we do about ILD? Well, that depends on the type of ILD that you may have. If there's inflammation, if there's scarring or fibrosis, or both. If it's predominantly inflammation, it can, in theory, be partially or fully reversible with certain medications that alter the immune system. That doesn't mean that it's guaranteed to go away, but there's that opportunity. Inflammation has a degree of being able to be reversible or can potentially go back to more normal lung. But if you've got fibrosis, I always tell my patients, scar is scar. You can't make that go away. However, there are medications that can slow down the rate of scarring, and something that if that's you and you're not on one of those medications, you could talk to your provider about to see if you may be a candidate. Now, what can you do about the pH if you have pulmonary hypertension from ILD? Well, many of you in the audience who have PAH understand that there are multiple different drugs because you're on multiple different drugs. Now you may be on 3 or even 4 drugs for your PAH, okay? And we being the medical community, have tried throwing those same PAH drugs, reaching into that closet and putting it into patients who have pulmonary hypertension from ILD. Unfortunately, most of those drugs have not proven to be terribly effective in pulmonary hypertension due to interstitial lung disease. But about 3 years ago, the FDA approved the first ever medication for PH-ILD, and it's inhaled treprostinil. That's the generic name for it. And this drug, there may be some of you listening who are using this drug for PAH. So it wasn't a new drug, it was a drug with a new indication because we were finally able to use to identify a medication that worked in PH-ILD. It's an inhaled medication, which we don't have too many of those. And one of the reasons we think that it's more effective in patients that have an underlying lung disease. Okay. So, it comes in two different forms. You can either get it kind of in a nebulizer type or in a dry powder inhaler, which is basically a small little stick that you put in your pocket. And it dilates blood vessels, making it easier for the heart to pump blood through the lungs. Exactly the same that we're doing in PAH, okay? So I want to, we focus a lot on medications, but I want to kind of finish up with a plug for pulmonary rehab. And I put a statement in here that I hope that you take to heart, because I tell my patients with PH-ILD, and by the way, PAH as well, but more so even in PH-ILD, that the single most important thing that you can do to alter the course of your disease is to improve your fitness. All right. And pulmonary rehab is the best way to get started with that, because it's hard to do things when you're always short of breath. And we've known this since the 1970s, actually, using this in patients with COPD. And it has been expanded to many other chronic respiratory illnesses, including pulmonary hypertension. This is something that's carried out usually at a hospital, but it's not an inpatient service. It's 2 to 3 times a week. It's covered by insurance. They provide you with oxygen, and they develop a plan to take you at your own pace. If you've never done pulmonary rehab and you have any limitations with your breathing, you really should ask your provider about that as potentially being an option. There are some online possibilities as well if you are not close to something. And finally, what's on the horizon for PH from ILD? Well, we have new preparations of inhaled treprostinil, so the same drug, which will offer some different options for patients that should be coming very, very soon. And then we also have some new medications that are being investigated in phase 1 and phase 2 clinical trials. This is a very hot area of pulmonary hypertension right now because there's such a big need because of the amount of patients with ILD. I've just listed here some resources for you to get reliable information. Please, please, please don't Google this, right? You know what happens when Dr. Google gets involved. It usually leads to a bad outcome for the patient because it just makes you more stressed and more confused. So use these reliable websites. And also, if you're interested in clinical trials as it relates to PH-ILD, there are currently 9 studies that are actively recruiting for this disease state, and you may live close to a center that would be offering that. Thank you all so much. And I hope that you enjoy the rest of the evening and the presentations.
Thank you, Dr. Kingrey. Thank you for shedding light on this vital key topic and breaking it all down for us. I know it is a hot topic, as you said here. So thank you for your time, and we appreciate that. Okay, up next we have Leah Barros, Doctor of Nursing Practice, Teaching Associate at the University of Washington Medical Center, Division of Pulmonary Critical Care and Sleep Medicine. She will speak today on pH and methamphetamine use.
Thank you so much for the kind introduction. My name is Leah, and I'm a nurse practitioner, and I'm a pulmonary vascular disease specialist. I'm out here in Seattle, Washington, and I work at the University of Washington Medical Center. And I'm honored to be here tonight and talk a little bit about what we know when it comes to methamphetamine-associated pulmonary arterial hypertension. So tonight we're going to talk a little bit about pH and meth. So just for my disclosures, I work also as a lecture series speaker for United Therapeutics, but I think that also we come into medicine with many biases. And one fundamental bias I have is that I believe that the truth of medicine is that we're liberated from the responsibility to judge others, and that this strips away the biases that come with social determinants of health, and frankly, just lets us be kind of cool people. And that's something that I really believe in my core and in my practice. So tonight I just want to explore a little bit about kind of how much toxin-induced PAH? That's a phrase that we'll use. So toxins can be anything that's associated with causing pulmonary arterial hypertension. And for the focus of today, we'll talk about methamphetamines, which is probably the most significant toxin that we are battling with in our current practice today, especially if you live in the western side of our country. So we'll talk a little bit about the epidemiology. So what do we know? How prevalent is it? We're then going to talk a little bit about effectively and compassionately caring for patients who struggle with methamphetamine associated PAH and substance use disorder. And then sort of what's next? What can we do as a community, both as patients, as clinicians, to best support these really important and vulnerable patients? So just in the general sense, remembering, pulmonary hypertension is a general term, right? And within that or underneath that umbrella of pulmonary hypertension, we have 5 groups, and those are the WHO groups of pulmonary hypertension, group 1 through 5. For the purpose of today's talk, we're going to focus on group 1, which is the pulmonary arterial hypertension. And all that means is that you actually have disease that is located inside the pulmonary artery. Within this group, there's several different types of associated sort of diseases or risk factors. We have, of course, sort of the I don't know pulmonary arterial hypertension. We call that idiopathic. We have the type where you inherit it from your genetic, inheritance, and then toxin-induced. So again, focusing tonight with methamphetamines. So in general, looking at epidemiology of pulmonary hypertension, there was a study that was done in 2016. It's not the greatest data, and it really used echocardiograms, which we all know is not the standard or the gold standard for diagnosing pulmonary hypertension, right? But this does give us sort of a general benchmark across the world of what types of pH are people experiencing. And I think what it shows us is that, this is in all parts of the world, right? pH in general and PAH specifically. If we look at prevalence, they sort of estimate that about 1% of the global population has pulmonary hypertension in general. And then as people age, that increases to about 10%. But when we break that down even further, you can see, looking at this, right? Most pulmonary hypertension is from the left side of the heart being sick, and that's that group 2, or from lung disease, which we just so nicely heard about, specifically with interstitial lung disease as an example. And that's because those are the most common diseases in the world, right? So we see that carries through when we think about types of pulmonary hypertension. And so then you say to yourself, okay, so if only kind of less than it's sort of estimated across here, such a small portion is a rare disease, such as pulmonary arterial hypertension, then of that, how much is caused by methamphetamines? And so this was not well studied for a long time. And in fact, only recently in the newest version of the guidelines for the management of pulmonary hypertension, did they just classify methamphetamines as a definite risk factor or association with PAH. Up until that, they said it was a possibility. And so only recently are we all sort of experts in agreement that PAH can be caused from methamphetamine use. So you can imagine that when we're looking at the literature, that there's not a lot out there, right? So what we do know is an article in 2022 was trying to compare types of pulmonary arterial hypertension sort of in the Western hemisphere and comparing that with Asian countries. And they found that majority of cases in the Western hemisphere were being classified as sort of the we don't know PAH. And that even in this study, they didn't classify necessarily methamphetamine associated PAH. So many of the reviews don't even mention this. Recently, people have gone back to look at registries. So what's a registry? A registry is a way that patients can voluntarily participate if your center or your provider is somebody that has the resources to put information into the registry. So they're voluntary, and it tracks information over time. So who's getting PAH? How old are you? What is your weight, your height, your gender, sort of all these things, and what is your association? So when we looked back at the Reveal registry, they reported in 2010 that about 5.5% of all pulmonary arterial hypertension was due to drugs or toxin-induced. The French registry more recently published data looking at the French registry cohort, and this has increased just in a short amount of time, almost twofold, right? It's almost doubled. So it's now 9.5% of PAH is due to methamphetamines. And why is that important, right? When we're looking at the data of meth use in the United States, we are having an epidemic. It is costing lives of young people in our country. Up until the fentanyl crisis, it was one of the #1 causes of overdose, and so early life lost. And it's costing our country significant amount of money, so millions and up to estimated of $2 billion in healthcare costs, in many impacts and loss of life. And so this is important, right? Our patients are struggling with addiction disease, and the rates are climbing rapidly. So Stanford recently looked at literature and published in 2018, looking at their cohort of patients they serve to try to help professionals understand that this really is a growing problem, and we need to pay attention and invest our time and our energy to understand this unique set of patients and how we can best serve them. And so looking at the most recent information out of the Stanford cohort, they found that actually about 20% of patients with PAH had meth-associated PAH. So now we went from estimations of 5 to 10% up to 20%. This is looking at patients from 2003 to 2015. And what it is, see, there we go. What it's finding is that it differs by region. So here in Seattle, we have a significant higher rates of meth-associated PAH, and that's for a multitude of different reasons, likely. And so they broke down across the nation. And so here in Seattle, where we live, in my personal experience, in our practice, about 35 to 40% of our practice is methamphetamine-associated PAH. So you can see that there are more and more patients that are needing special services, right? Because this is not just treating pulmonary arterial hypertension. This is also treating addiction disease, which is very much a disease and requires the same specialized attention as does pulmonary vascular disease, right? So in my clinic, this is something that we think about a lot, we talk about a lot, and a group of patients that are very important to us. So what do we know? So the Stanford cohort took a look and said, what do we know about methamphetamine-associated PAH? So as we talked about just a little earlier, methamphetamine was only defined as a definite risk in 2018 in the guidelines. So only recently are we having consensus across experts that this is something that we need to be looking for. And we know that the pathology is somewhat similar to other forms of PAH, right? So we know that the changes that are happening inside that artery are similar to other things that can cause PAH, and that much of the treatment is also similar. So we're going to use pulmonary vasodilators, right? We're going to use medications to try to make that artery more open, make it larger. That way the blood can flow more easily from the right side of the heart, cross that pulmonary artery to the left side of the heart, and increase how much blood the heart can pump out and around the body. So we're going to use those same medications that we would if somebody came in with idiopathic pulmonary hypertension. And then what we know about patients that come in is we know that in general, they tend to be a higher percentage, they tend to be male versus female. They tend to be younger compared to idiopathic pulmonary arterial hypertension population. And this came out of studying the data from the PFAR registry. We know that they have lower socioeconomic status. So we know that they have multiple barriers to their engagement in care. And so when we're thinking about how do we best serve these patients, that becomes really important for us to understand, right? These medications are not cheap. How do you access these medications? How, if you don't have stable housing, how are these medications being delivered? How are we taking into consideration the whole picture when we're thinking about the care for patients who struggle with methamphetamine-associated PAH? So this becomes really important that we're starting to describe. And we know that they have a worse cardiac performance when they arrive into our clinic. So what we know is that the PFAR found that they had lower cardiac outputs, meaning they had sort of more severe levels of heart failure, right? We know that pulmonary arterial hypertension, if gone untreated, can cause right-sided heart failure. So by the time patients with meth-associated PAH are showing up for their initial visits in clinics, they're having worse or more severe levels of heart failure. So there's even a higher urgency to start therapies right away. And if you have barriers like unstable housing or unstable financial resources, or insurance, this can become a real issue. We also know that they have worse right atrial pressures. That just means that they hold on to more water on the body, right? And we know that when the heart can't pump as easily, holding on to more water can put that heart under a lot of stress. It also makes people feel worse. So their shortness of breath when they try to walk is really significant and limiting to the quality of their life. The edema and the swelling, this can increase risk of wounds and other healthcare complications. And we know that there's right ventricle stroke volume is worse. So we know that the right side of the heart can't pump that blood out across the artery as easily when you compare patients with meth-associated PAH compared to like idiopathic pulmonary arterial hypertension. And we know that there is a dose response relationship. So we know that sort of more years at higher doses of methamphetamines is increased risk of severity and development of PAH. And we know that prognosis sort of remains limited. And we know that they receive less or delayed prostacyclin therapy. And this is huge because what we're going to talk about in a minute is that all patients struggling with pulmonary arterial hypertension deserve access to care in an equitable way. And we know that patients that carry this diagnosis have received less or delayed in their prostacyclin therapy. And so for people who are on today that struggle with methamphetamine associated PAH, I think it's important that you advocate for yourself. I think it's important that you know that these are therapies that, if important or warranted in your care, are something that you deserve access to. So there is a paper that tried to look at prognosis for patients, and in just the Stanford cohort, patients who struggle with methamphetamine, ongoing methamphetamine use, and meth-associated PAH don't live as long as those who have idiopathic PAH. We don't understand why. We can make assumptions and generalizations, and probably how we talked about earlier, that there's several barriers that are getting in the way of their ability to access care, and those could be financially, resources, education, stable housing, things like that. But we do see that it affects how long people can live when they struggle with meth PAH. So I think the next really important question is, how do we improve care, right? How do we improve care for patients living with methamphetamine-associated PAH? I think it's a really important question that we're asking ourselves. And I think that the answer to that question falls in partnership with patients and providers that are trying to figure out a solution together. So first and foremost, without question, there's more research needed. It is not uncommon that patients with meth-associated PAH are often not included in clinical trials, right? They are often not at the center of expansive studies. And so we as clinicians need to do better, and we need more research. We need to be asking these questions and investing our time and our resources into answering them. We also have to work to destigmatize, right? I mean, addiction disease is nothing different than any other disease. And I wouldn't expect somebody to be able to will themselves better or to go out and treat a disease without the support of their community, which includes their clinicians. And so we really have to work hard in our communities to destigmatize the sort of the negative connotations that people can associate with addiction in general and methamphetamine specifically. And here's what we do now. We know that patients adhere to therapy, right? I think one of the stigmas is if people are struggling with addiction, it's a barrier to their ability to take their medications as prescribed. And that probably influences if prostacyclins are considered safe or not safe, right? And looking at the New England Journal of Medicine, or looking at the Stanford cohort, we found that almost 50% of patients adhere just fine to their medication regimens, even despite the fact that they're struggling with addiction or when they have meth-associated PAH. And this is close to patients with idiopathic PAH, right? 60% of idiopathic PAH patients adhere to their medications as prescribed. So we know that patients take their meds. We also know that they can safely and effectively be enrolled in clinical trials. At the University of Washington, we did a rehab PH trial. And what we published and what we found is that we enrolled patients with meth PAH. And while they had barriers to participating in that clinical trial, they did so. And they participated, they completed the research studies at the same rates as our patients who had other types of PAH. And I think this is huge. So even if we look most recently at the Cirulis trials, right? We look at recent clinical trials that have just been published, and these did not include large populations of patients with meth-associated PAH. So when we're trying to say these medications work for specific patients, it's hard if we don't include them in the trial. So if you hear of trials happening, if you're somebody who has methamphetamine-associated PAH and a provider is talking about ways to be involved in research, I encourage you to consider that, learn about that, advocate for yourself if that's something you're interested in doing, because I think that's really important on how we're going to be able to provide the best level of care for the unique needs of patients with meth PAH. We also know the patients can receive all therapies, and that includes transplant, right? Having just a history of methamphetamine use should not preclude you from accessing resources. Sobriety is an important part of this journey and maintaining sobriety in order to be able to be eligible for transplants or advanced therapies. But carrying this diagnosis should not be an exclusion criteria to getting equitable access to care. And we know that this takes a team, right? This takes a whole community. So some of the unique needs of patients with meth-associated PAH is that we partner with our addiction medicine specialists, and all of our patients are referred to our addiction medicine specialists to make sure that we are really trying to address the whole person. So we're really trying to get at Is there any undiagnosed mental health conditions? Are there any social emotional conditions? Are there any sort of addiction medicine treatments that we could be offering patients and aggressively treating their pulmonary vascular disease, right? This is a vulnerable population that we care for that deserves our best work. We include our social worker, and we also consider medical therapy. So there's a new paper in New England Journal of Medicine that just came out that is looking at medical treatment for meth addiction. So if you're somebody who's struggled with this, there are potential medications that can help treat methamphetamine addiction. And that was a study that looked at the combination use of bupropion and naltrexone. And they found an increased success in sobriety over time. And so I think this is an exciting time. I think that our community is starting to pay attention. And I think that we're deeply passionate about serving, and I know I'm deeply passionate about serving patients with meth-associated PAH. You have unique needs that matter. So thank you very much. That's my fantastic team. And we all feel very privileged to care for this amazing group of patients.
Thank you, Leah. Wow. I learned a lot just in those few minutes with your presentation. The numbers are staggering there, very staggering. And we must take a deeper dive on this topic in the future as the numbers are increasing and more research is being done and needed, as well as clinical trials. So thank you for sharing that great vital information with us today. Next up, we have Tonya Zieger, respiratory therapist in pulmonary medicine at Mayo Clinic, Jacksonville, Florida. Her topic today and oxygen therapies. Thank you, Tonya. We'd have had you several times in our support group topics, and great information and very needed within our patient population. So thank you for being here today, presenting on oxygen therapies.
Thank you for having me. I'm Tonya Zieger. I'm a respiratory therapist, but I'm also a pulmonary hypertension coordinator of 25 plus years at Mayo Clinic in Jacksonville, Florida. So I am kind of the oxygen person, as we would say. My all-time favorite quote is from my mentor, and he said, "There's no more potent vasoconstricting force than hypoxemia. Therefore, no patient medication can work optimally in a hypoxic environment." What I usually say to patients is all the medications that you take are to open up your blood vessels. And when you let your oxygen levels drop below 90% and don't use your oxygen, your body's response is to constrict those same blood vessels that we're trying to use all this medicine to open them up. So what are our O2 challenges? Well, we've got portable concentrators mass marketed to patients, misinformation from suppliers and manufacturers, disappointment and a lot of anger when we try to relay the inability of the equipment to actually supply the patient with what they need, difficulty with getting appropriate portable oxygen systems for patients within their insurance allowances, and challenges with the O2 companies' reimbursement issues. Also, the fact that they do need hand-signed paperwork, and if the physician is out of office, sometimes that can delay the paperwork. So, what do we need to script? We hear routinely from oxygen companies that, oh, we just don't know. What they want is an oxygen saturation less than 89% or a blood gas oxygen level of less than 56 on room air. It could be with sleep, but if it's determined that during sleep, you won't actually get a portable source of oxygen with that prescription. If the oxygen saturation is greater than 88% or greater than 55 millimeters of mercury, and you need portable oxygen provided, the patient's going to need to exercise to show desaturation or a number drop to those numbers or less. But during that same visit, the patient must be placed on supplemental oxygen to show that the patient improves while they're on oxygen. They want to see that you don't actually have an oxygen drop while you're actually using the oxygen. So I want to just take a minute here and explain to you pulse oximetry. Now, everybody who's ever been one of our patients knows that we routinely use these little finger probes to monitor your oxygen percent. And they're very, very useful. They're great at establishing a baseline, monitoring if we need to titrate oxygen, evaluating patients with severe disease, just general assessment. They're fantastic. However, the way the pulse oximetry monitor works is it uses an infrared light that goes through your finger or your ear, wherever you have it attached. It looks at the weight of the red blood cell. It knows the weight of an empty red blood cell, and so it assumes that everything else other than the empty weight is a percentage that's attached of gas. Now, that gas could be any gas. It's not necessarily oxygen. So that can be a little tricky. So we have to be really cautious if, say, somebody had carbon monoxide poisoning. Carbon monoxide actually has about 220 times the capability of attaching to the red blood cell as opposed to oxygen. So you can just imagine, the oxygen is trying to get aboard the bus and the bus is full with the bad stuff. So you have to be a little careful, because if you're using the pulse oximeter, it's going to say that the patient's got 100% gas attached. And you're going to be looking at this patient and going, why are they so short of breath? I don't understand. When you would actually draw blood and do a blood gas, you could actually see there that a lot of that percentage of gas is not good gas. It's not oxygen. If a patient's moving or shivering, the machine cannot tell the difference between a shiver and a heartbeat. So a lot of times those can be inappropriately read. If you have a heavy nail polish, dirt or artificial nails, blue nail polish will read low, red nail polish will read high. If you're anemic, your oxygen delivery is going to look like you've got 100% oxygen or 95% oxygen. But if you have nothing for that oxygen to attach to, if your hemoglobin is low, then you're still going to be really short of breath. If you have poor perfusion, cold fingers, low blood pressure, you're in shock, you have a cold environment, all of these things can actually cause the pulse oximeter to not be very accurate. So you just have to be kind of careful when you're using it. Additionally, if your oxygen level is less than 80%, a lot of times, because they're trying to err on the side of caution, they will actually read higher than the patient actually is, particularly in those patients that have darker pigmented skin. Oops, sorry. There we go. So additional necessities, if they're ordering oxygen for you, we've got to have a face-to-face visit with a physician within 30 days of the actual prescription. And they have to note in that face-to-face that you need oxygen or you're continuing to benefit from oxygen. The qualifying testing has to be within 30 days of the prescription and delivery of the equipment. And acknowledgement of the oxygen company receiving the order is not the same as the delivery. And if the requested liter flow of your oxygen is greater than 4 liters, Medicare requires that you have documentation of a low oxygen level while you're on 4 liters of oxygen. If any of these qualifications aren't met, the DME company will actually require that everything be redone. So it's really, really important to make sure that time frame is adhered to. So portable oxygen options. Everybody is always very interested in what options are out there. We've got the standard aluminum tanks, which we've always had. We've got the tanks that have the demand valve conservers. where the patient only gets oxygen when it pulses. The portable oxygen concentrators, they can be pulse flow or continuous flow. Self-fill oxygen systems can either be pulse or continuous. Home concentrators, however, if you're using a self-fill oxygen tank or an oxygen system, while you're filling your tanks, you're not getting the full liter flow of your oxygen. Sorry, my dog is deciding that she wants to be part of the presentation. The portable tank is only going to be filled with whatever percentage oxygen that concentrator provides. It can be actually as low as 86% and still be working properly because a concentrator is not going to concentrate to 100% oxygen. And again, that's not a big deal if you require low flows. But if you're on high flows, it could really be a big difference and be insufficient for you. Liquid oxygen has been a huge help, however, much more difficult to receive in the last few years. And more companies are deciding to not provide liquid oxygen anymore. If your oxygen level or if your oxygen need is greater than 5 liters, it's important that your doctor prescribes for that high flow concentrator. And it's something that's come up recently is that even if you need 8 liters and you say a high flow concentrator, that leaves it open to judgment, which I don't understand. But your doctor's office actually has to be specific and say they need a 10-liter concentrator. And that way you can get what you need. So the top question on everybody's mind, how can we get the highest liter flow for the patient and still be as portable as possible? So we have a few things to consider. If we're talking about the pulse conserving devices, we need to worry or discuss what is the patient's respiratory rate? What continuous liter flow is required? Will the conserver allow continuous flow and pulse flow? How quickly does the patient respond to oxygen flow increases? These are all really important because these conserver technologies have all been integrated with all various oxygen options. So the types of demand or pulse conserving devices, I'm not going to go into this and bore you with the inner dynamics of it. I just want you to realize that they all operate a little differently. So we have pneumatic, which usually has a dual cannula so it can sense inhalation versus exhalation. We have electric intermittent breath delivery. In that case, it's always going to deliver the same volume. 1 means it's going to deliver 1 breath out of every 4, 2 is 2 breaths out of every 4, 3 is 3 breaths out of every 4, and 4 means it will deliver every breath. Every breath delivery, which is probably the most frequent that we see, actually uses a solenoid that opens up and delivers a different amount of oxygen per puff. So I'll go into that a little bit with you. I will tell you that it does not compare to liters per minute, ever. So a lot of times you may need a number 6 pulse if you only require 4 liters of oxygen. So just something to keep in mind. So oxygen tanks and usage charts, again, not going to bore you with this. I just want you to realize that the pulse dose does drastically change how long your tanks are going to last. That's fantastic as long as it keeps your oxygen levels greater than 90%. That's the key. Again, we are giving you all kinds of medicines to try to open up blood vessels. And the last thing you need is something as minor or simple as the oxygen to really bring you back down. So portable concentrators and self-fill systems, there's a ton of them on the market, and I apologize up front. My latest is not truly up to date. I've got several that I need to add. These two on the side over here are actually self-fill systems. Oxygen companies love them because they can deliver them to the patient with usually 2 cylinders, and the patient is tasked for filling their own cylinders, and they, quote unquote, don't have to wait for the oxygen company to deliver tanks. Why is that important? Because we have a lot of challenge behind the self-fill systems that I'll get to you in just a second. These next few slides are a little cumbersome, but I want you to realize that there are options out there that do provide continuous flow. They do all have different pulse flow settings as well, and they all give different amounts per number on the dial. So why is that important? It's because you may be totally different than your next door neighbor who also has pulmonary hypertension and also needs oxygen. It has to do with how much you inhale and your dead space and your respiratory rate. And these are things that can't really be easily predicted. So what I tell every patient is if you are thinking about buying a portable concentrator, or if you're using a portable concentrator, always make sure you have a pulse oximeter so that you can monitor and make sure that you're getting what you need. And then the second part of that is make sure if you're buying it outright that they have a good return policy. So you can test it out, and if it doesn't work for you, you can return it. Another important part about these flow sheets that I've done is it also tells you down here the weight of the machine, as well as how much it weighs with its battery. Again, I know a lot of times people have additional issues with mobility and trying to carry things. Those can all be considerations for portable oxygen issues. These, again, are all of the pulse flow. These do not do any continuous flow. The one take-home message I want to give you for the portable oxygen concentrator is there is not one portable oxygen concentrator that will give you over 3 liters per minute, ever. So it can have a number, as on this previous screen, it could have a number. Of course, it's not going to go back for me now. It could have a number that goes to 15, but that 15 is not liters per minute. That's a number 15 that is really related to how much flow you're getting when you inhale. That's a pulse flow. So the home fill systems, I want to touch briefly on this because if you look at these tanks, they look remarkably like the ones that you would have delivered from the oxygen company that come full. The challenge to the home fill system is a few things. The nice part is that they do, the Invacare model does attach to any Invacare home concentrator. The challenge there is that as you are filling your portable unit or your portable tank, your liter flow that you're actually receiving while you're filling is going to drop by 1/3. So if you have, say, your oxygen concentrator set on 9 and you're filling your portable, you're actually only getting 6 liters per minute. Not a big deal if you only need 6 liters. It is a big deal if you need 10 liters routinely, and now you're cutting down for the hour it takes you or more to fill your tanks. So it's really important to know this so that I actually discovered this and kind of went into a deep dive when a patient came into me and their issue was that they couldn't understand why when they sleep, they always wake up tired. You know, a lot of times they wake up with a start. Well, after further discussion, we found out that the husband was actually filling her tank while she was sleeping. So he effectively, unfortunately, did not realize, but he effectively had decreased her amount of oxygen and therefore made things worse. So demand devices for oxygen delivery equipment, whether it is the little head that goes on the tank, whether it's a POC, no matter what, they all operate a little bit differently. So it's important that you actually titrate to your needs. And it may be very, very different than what the DME company is going to supply. So it's important that if your doctor says, well, okay, I think you might be able to do pulse flow, ask them if they can do a prescription for your oxygen company to come out and test you with what they are going to provide for you. Unfortunately, years ago, we thought, oh, well, we'll just buy some of these and we'll be able to test the patient in-house. Never works out because a new regulator will come out, different solenoid settings, and you just have no idea. Again, if you're purchasing, make sure it has a good return policy, 30 days. Very costly and disappointing if you pay for something that can't provide you what you need. So things to look for. If you sleep with a CPAP or BiPAP machine, it's really important that if you're going to use your portable oxygen concentrator for travel, that you have a continuous flow option. If you only have a pulse flow portable concentrator, you cannot connect it into your CPAP or BiPAP machine. The way the machines work is that the CPAPs and BiPAPs is they're a closed system. So if you put in there a pulse flow machine, it's actually going to effectively break that system. So it's important that you do that. A lot of times it used to be that we could depend on our oxygen companies to say, oh, wait, if you're going to use this with a machine, you have to have continuous. Now they are a little more lackadaisical. They sometimes forget those things. So I want you to be your own advocate and go forth and say, okay, I've got to double check this. Considering what you need when you're in the doctor's office. If you require low flows, you should be fine with the portable concentrator that will only do demand. If you need high flows, you might need a different portable option. Look at the total amount of oxygen it can produce. Some of the little cute portable concentrators, unfortunately, produce less than 1 liter per minute. Those machines definitely cannot give you 2 liters per minute because they can't even produce that amount. Again, making sure that you have a decent return policy. The reason I drill that home is because I have been the recipient of too many phone calls where they say, well, what am I going to do with this now? It's just, something to set my books on because it's not providing the patient what they need. So what happens for patients who need more than 3 liters? You could do the standard aluminum tanks. They don't last very long and they're cumbersome. They are less heavy though than the old steel ones we used to have. Portable concentrators that provide up to 3 liters sometimes may work if you use a conserver device that is a reservoir conserving device, and I'll show you those in a moment. The continuous flow models are always going to be heavier than pulse dose models. And remember, your oxygen concentration of the portable oxygen concentrator is not going to be 100%, as opposed to if you have a tank. When you have the tanks delivered from your oxygen company, that is 100%. Again, self-fill systems, possibly okay with continuous flow if you need more than 3 liters. Again, you've got to be really leery of what you need while you're filling. Really important information. Liquid oxygen does have the ability to give up to 15 liters, and it's 100% oxygen with continuous flow. It is a little cumbersome, both for filling and carrying, and it's not something that you can fill it the night before you have an appointment the next day because it will evaporate. And unfortunately, more and more problems as far as having a DME that will actually provide it. So what is a high flow conserving device? We use a ton of these. They're called OxyMask or OxyArm by Southmedic. If you look at this style here, there's a little triad here, and that actually goes between the nose and the mouth. and that's where the flow goes. So it takes away the issue of somebody being a mouth breather or a nose breather. It actually does a phenomenal job of decreasing the amount of flow a patient needs, even though it has all of these openings on the mask. Two things, it actually helps people that are a little more claustrophobic. They don't feel as claustrophobic. And then the second part of that is it's amazingly comfortable as opposed to a full mask that's really heavy and hot. The pendant oxidizer and the mustache oxidizer work by actually having a little reservoir that it's holding the oxygen in. Again, great at being able to turn your flow down a little bit. However, if you look at the bore of the tubing that goes around the ears, they're very, very thick. And unfortunately, sometimes people don't like the idea or don't like the fact that they can hear the air so readily. So a lot of times, believe it or not, people actually prefer the mask over the pendant. So it's just a personal preference. So what do we need to know about these high flow reservoir conservers? They can't be used with pulse flow devices at all. They should never be used with humidity because unfortunately it's got a reservoir, and when that reservoir gets wet, it could mold or have bacteria grow. It is a higher cost for the DME companies to supply, and smaller DME companies may not supply them. If it is the oxy mask that the patient's been tested on, we make sure that our prescription specifically says oxy mask by South Medic. If not, that kind of leaves, again, a gray zone that the DME company will say, oh, well, a mask is a mask, and they'll give you a simple mask, and it won't do the same thing as what we need it to. They actually have to be prescribed as the delivery device. And so, again, your physician has to be very clear with the prescription and the flow rate that it's with that conserver. So in other words, they would have to say patient requires 4 liters continuous flow with nasal oxidizer with exertion. They can actually decrease your liter flow that you need by 25 to 50%. But again, all needs to be individually titrated. It totally has to do with respiratory rate, how deeply you breathe. All of those things are really important. And we should never just assume a flow rate adjustment. So what do high flow users need to know? The pulse systems are not liter per minute. They are in milliliters per puff. And sometimes that's okay for a patient. Sometimes it's not. But if a patient requires more than 6 liters, they really need either for portability, compressed oxygen, the gas tanks, or liquid oxygen systems. The liquid oxygen for portable use is much more efficient than compressed gas or compressed oxygen in a gas tank. And believe it or not, the liquid oxygen is actually less pressurized tanks. So their tanks are actually pressurized only to 21 PSI, as opposed to the big tanks that we all see that are 2000 PSI. So it really doesn't need a lot of protection, I guess I could say, against dropping or falling, things like that. And the liquid oxygen reservoir is simply this big thermos type container that minimizes warming and evaporation. High flow oxygen with liquid would last a little bit longer, obviously. So these two over here on the, I guess it's my left side, actually are gas tanks, the cylinders that we are all used to seeing. And the two over here are actually the liquid reservoirs. And you can see that they do last a little bit longer. Be aware that if you are conserving your oxygen by going to pulse flow, if you are in trouble and you're finding that you're more short of breath, you may actually need to turn your oxygen to a continuous flow number that is lower than the pulse flow number that you're trying to use. So there are difficult questions, we all know that, but there's also answers. So it can be really frustrating and time consuming, but it really is achievable. You just need to work with your oxygen company as well as your physician, and you've got to reach some sort of agreement as far as comfort, portability, and effectiveness. If you feel that it's too cumbersome, you won't use it. If it's ineffective and you don't feel like you're better with it, you won't use it. But once you know kind of your delivery options and understand the pros and cons of each, you can make an informed decision. So together you can get a viable plan together. Take-home messages is keep in mind that demand, I'm going to drill it home, is not liters per minute, but is related to milliliters per breath, and they vary by device. No matter how adamant a DME provider is regarding the capability of the equipment, always question it. There is absolutely no portable oxygen concentrator to date that has the ability to provide more than 3 liters per minute oxygen to a patient. Again, if you're using the demand equipment during a crisis, you may be better off to turn your oxygen to continuous flow, to whatever that continuous flow is, say it's a 2, as opposed to it being a number 6 pulse flow. And always let your provider know if you're filling your portables at home or if tanks are delivered full from the DME. Really important if you find that your oxygen level is dropping when you're at home, but when you're in the doctor's office and on their tanks, your oxygen levels are fine. That may be a key problem. And I just want to thank you for having me, and please feel free to reach out if you have any additional questions.
Thank you, Tonya. Greatly appreciate you. Another in-demand topic that continues to change. And so as you continue to work with us to educate our patients, that is great. Very, very good information in detail. So thank you for your presentation. Thank you. Okay. Next up, we have Dr. Meghan, Cirulis, internal medicine, adult pulmonary critical care, and pediatric specialist at Intermountain Health in Murray, Utah. Her topic tonight will be emerging therapies. And here she is.
Well, thank you for that introduction, and we can just jump right into the next topic, which is emerging therapies in pulmonary hypertension. So before we talk about emerging therapies, I think it's important to review really where we've been with therapy over the last several decades. So as many of you are aware, we've really focused our treatment on 3 therapeutic pathways: the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. And all of our drugs over the last 20 years have really been one of those 3 part of one of those 3 pathways. And you can see here, looking from 1995 when epoprostenol was first approved until 2015 when selexipag was approved, it's really a lot of the same colors. So we've been kind of stuck in the same treatment pathways, which have provided a lot of benefit, but still not as much as we feel like is possible. So where are we now? I think the exciting thing in the last year is that we've added a 4th treatment pathway. So the figure finally gets to change. And instead of the endothelin, nitric oxide, and prostacyclin pathways alone, we also now have this activin and BMP pathway, which is where sotatercept or Winrevair comes into play. And similar to the other pathways, it's acting on this communication between the endothelial and the smooth muscle cells, and really trying to rebalance the pro and anti-proliferative signaling pathways. And this is just a figure from the STELLAR trial, which was the phase 3 trial published regarding sotatercept, and just showing that there was a significant improvement in 6-minute walk distance in the patients that were on sotatercept in addition to their background therapy as compared to the patients who were on placebo. And so this has been a really exciting addition to our toolbox of therapies that we can use for pulmonary hypertension. I think the other important factor to keep in mind in terms of where we are is that therapy currently is guided by risk stratification. And so this is an excerpt of an algorithm from the most recent proceedings from the World Symposium. And you can see that, right off the bat, we do an initial risk assessment that looks at things like the 6-minute walk test, BNP levels, and functional class. And then that helps guide the practitioner down a pathway of sort of how aggressive to be with treatment. And then we frequently reassess those risk scores in order to decide whether we can stay on the current treatment regimen or if we need to add additional treatment. And the other thing I'll point out here is that all of these therapeutic options are combination therapy. So that has really been a paradigm shift over the last decade as well, where monotherapy with any one agent is really not recommended anymore. And just as a review, the combination therapy strategy has really been supported by both observational studies and clinical trials. So this is a nice transplant-free survival curve. So looking at patients who in the red got triple combination therapy up front versus those who got only dual combo therapy or monotherapy. And you can see that the patients who received triple therapy up front definitely have improved survival in this retrospective observational investigation. And we had the Ambition trial that looked at ambrisentan and tadalafil, but we now also have the Adieu trial, which looked at macitentan and tadalafil as a fixed dose combination and showed that compared to either drug alone, the combination of the two was associated with a greater treatment effect in the pulmonary vascular resistance. This is just an example of one of the trials, that we've looked at with combination therapy, but definitely informing our current practices. So then let's talk a little bit about where I see we're going with pulmonary hypertension treatment. So really, I think there's a lot of focus right now on the challenges and changes in clinical trial design. And I think as patients, you will really be at the forefront of helping us to figure out these next these treatments moving forward, as well as sort of what is important in terms of how we design trials. There's been a lot of focus on the 6-minute walk distance for many years as like the main outcome in clinical trials, but there's some thought that that may not be the best surrogate for what really matters in terms of treatment efficacy. So there's discussion about using multi-component clinical improvement endpoints, using risk scores, using actigraphy, which is basically how much a person is moving during the day or during their life, cardiomems, which many of you have probably heard about, which is an implantable sensor that keeps track of hemodynamics. And then there's a lot of interest in if we can identify surrogate biomarkers, so basically lab tests or other diagnostic tests that can help us predict the more important outcomes such as mortality, survival, etc. And I think the bottom line is that patients are really becoming more complex. There's an increase in coexisting conditions, and most people that are entering into these clinical trials now are already on some sort of background therapy. And because of that, clinical trials are becoming more complex and more expensive. And so I think we may also see over time a shift in trial design. This was also from the latest proceedings from the World Symposium, and it's just an example of a different type of trial design, one that was used more in COVID trials, so that you have sort of multiple arms of a trial getting different treatments compared to a standard of care group. And those treatment arms can kind of be switched out as you either say drop one treatment because of a safety signal, or you identify a new treatment that you would like to add. And that's an example of platform trial design that we may see becoming more common in pulmonary hypertension clinical trials. And then lastly, I think there is this thought about having a shift from this sort of feel, function, and survival mindset, which is how we've typically framed our goals in terms of treatment outcomes. So we want the patient to feel better, to function better, and to survive longer. And I think we're reaching a point where we may be able to actually look at disease modification. And so whether or not a drug can actually change the course of the remodeling that's happening in the pulmonary circulation. And some examples that are thought to maybe have possible disease modifying effects would be sotatercept and seralutinib. And again, that's just, we really still need to define how we, what we call a disease modifying drug, but I think that's something that will hopefully be coming down the pipeline. I think overall the future is really bright. There's over, about 25 ongoing clinical trials in PAH alone. And when I think about our emerging therapies, I really put it into kind of 4 categories. So new drugs, new ways to deliver or improve current drugs, old dogs, new tricks, so kind of old medications that are being utilized in different ways. And then really we're broadening our treatment options outside of the narrow group 1 PAH indication as well. We'll just run through a few examples of each of these groups. So in terms of new targets or new drugs, the kinase inhibitors I think are exciting next line therapy. So seralutinib, which is being studied in the PROSERA phase 3 study, has had exciting and promising early results. There's increased interest in looking at hormonal targets such as DHEA and tamoxifen that really play to the sort of estrogen pathway relationship there is with PAH. And then also activin signaling, which is the pathway that sotatercept is in. There are other molecules or other drugs that are being investigated within that same pathway. In terms of new ways to deliver or improve current drugs and pathways, ralinepag is being studied in the ADVANCE clinical trial and is sort of a relative to selexipag, but maybe more potent and more selective. We are looking at doing higher doses of currently approved therapies, such as the higher dose of macitentan in Unisys. We're experimenting with inhaled instead of oral therapies. So MK5475, which is an inhaled soluble guanylate cyclase stimulator. So something similar to riociguat or Adempas is being investigated in the Insignia PH study. And then I think also looking at whether we can deliver some of these medicines less often, so make them less cumbersome for the patient. So there's an inhaled treprostinil formulation that could be given twice a day instead of 4 times a day, which for those patients on Tyvaso, I think would be a huge reduction in dosing frequency. And then we have medications that are being looked at and sort of repurposed in the PAH arena. So the SGLT2 inhibitors like empagliflozin and dapagliflozin are very exciting drugs in terms of heart failure management. And I think there's a lot of interest whether they will also be useful in PAH. Metformin, which is a diabetes drug, and spironolactone, which is sort of a blood pressure drug that acts on the salt and water handling in the body, is also being looked at in PAH. And then we also have increasing treatment options outside of group 1 PAH. So for example, in group 2 pulmonary hypertension, we have a clinical trial ongoing looking at sotatercept. And then there's also the LEVEL study, which is looking at levosimendan in HFpEF pulmonary hypertension. In group 3, there's the ongoing COPD PH study looking at the MK5475. And then in group 4, I think there's increasing both national and global availability and expertise with balloon pulmonary angioplasty and really figuring out kind of its role in the treatment algorithm for CTEPH alongside medical therapy and surgery. So to sum it all up, I think we had a really strong start of, several decades worth of drug development in the 3 core pathways, and we've just begun to explore outside of those pathways and sort of define new medications and new targets. And I think really there's just a lot of excitement and hope in the pulmonary hypertension world that we can not only make people feel better, but hopefully eventually figure out a way to cure or at least reverse this disease process. And that's what I have.
Thank you, Megan. Next up, we have Dr. Patricia George, Director of Pulmonary Hypertension Program at National Jewish Health in Denver, Colorado. And she's also the president and co-founder of Team Phenomenal Hope. Today, she will speak on foundations of wellness, essential pillars for thriving with pulmonary hypertension. Hi, Dr. George.
Thank you so much. Can you hear me okay?
Yes, we can.
Awesome. And that's former president. Hap Farber is our current president and amazing. So I just want to make sure he has those props. So I'm so excited to be here tonight. And Meghan, thank you so much for such a great overview on medical therapies. As somebody who's been in the field for a few years now, the future really is bright, and it's certainly exciting. And in fact, it makes us smile, knowing what we have now, but even more so what's coming down the pipeline, how she described, we've changed how we utilize medical therapy with combination therapies, et cetera. And so the future certainly is bright. But, when we think of medicine, we think a lot about medications. A lot of people think, okay, medicines, drugs, pills, IV therapies, et cetera, which are very, very important, of course. But I want to talk about another element of our prescriptions that's also important. And so if I said to you, think about health, what do you think about? And a lot of people might think about eating healthy food. And it's dinner time here, so I'm a little hungry, and that looks really good right now. You might think about meditation, mindfulness. I think about riding my bike. Others, as you can see right here, but others might think about other activities of being active, moving, being able to walk and feel healthy. Sleep. People may think about sleep and interacting with human beings and animals and living a healthy lifestyle. And so we talk a lot in our clinic about this concept of pillars of health. That in addition to medical therapy, I will talk with all of my patients about where they are on these 4 areas of their life. And so those pillars are sleep, fuel, mind, and movement, exercise. And this isn't anything new. I mean, Hippocrates thought about how health was an important intersection between, what we eat and how we move and the things that we do to be well. And so it's part of Ayurvedic medicine. It's part of traditional Chinese medicine. So this holistic approach is certainly not new. And so we think about these 4 pillars, these 4 areas when we see patients in our clinic. And so, a lot of times people think, I'm going to go get my diagnosis and here are my medications. And there you go. You go on with your life taking pills or important therapies, which are crucial. But I would offer to us the importance of a complete diagnosis and treatment plan. So if you're attending tonight's webinar, by definition, you're an empowered patient. You've empowered yourself to come and learn about, these important topics. And I'm so glad you're here. And, when we frame it at our institution, and I think at all of our institutions, we think about having a complete diagnosis, making that accurate diagnosis of pulmonary hypertension. What type, what group, as you heard about earlier, there are different groups. What's the severity? How sick is someone when they present with pulmonary hypertension? Doctors call that risk stratification. Some people may call it your PAH status, but it's sort of trying to say, okay, this is the diagnosis, this is how severe it may be. And then, of course, up front, it's important to educate you about the disease that you have as a patient, or that your loved one has as a patient if you're the caregiver. It's important to make sure we get you on the best medications to treat whatever group, whatever type of PH you have and associated diseases that you may have. And as you heard, it's important to maintain your oxygen level greater than 90%. But in addition to that, it's so important to hit these other pillars of health. So a lot of times when I first see a patient, I ask, hey, do you have any sort of nutritional practices? Like, do you avoid sodium? What do you do with your fluids? Are you vegan? Are you carnivore? Are you what in between? Like, just to get a starting reference for what do people do? What are their practices? And there's certain things that people could do to perhaps shift their health, even from a nutritional perspective. The second thing is sleep. In fact, nothing works if your sleep is trash. So one thing people think about, of course, in pulmonary hypertension is treating sleep apnea or treating nighttime low oxygen levels, what we call nocturnal hypoxemia, which we see a lot here and at our elevation and higher. So, it's certainly important to do that. But in addition to that, it's important to have good sleep hygiene. That doesn't mean bathing before going to sleep. That means doing, although that's nice too, of course, but that means doing all those important things like that are actually hard in our modern society, right? Like avoiding screen time an hour before bed, avoiding caffeine after noon, having a very regular sleep and wake schedule and maintaining that versus being all over the map. Not waking up in the middle of the night, eating in the middle of the night, things like that. There's several things that people can do to really dial in and get good quality sleep, in addition to treating sleep apnea if it's present. Mind, mental health. So another thing, none of this works as well, nearly as well, unless we address any underlying mental health issues. And living with a chronic condition certainly is a challenge, right? And it causes a shift in how you might view the world. And so it's important to address that. It's important to treat mental health, whether it's through medications and, therapy, and trying to really understand your life in the context of the condition you have and just in general. Mental health is health. Social connections are a really important part of mental health. Like, we're human beings and are social creatures. Now, not everyone's an extrovert. Some of us are introverts, some of us are extroverts, but even so, having quality connections and friendships is important. And of course, managing stress is a super important part of mental health. So whether that's dialing in these other pillars, whether it's therapy, whether it's just figuring out how to address and lower, maybe saying no to things that are depleting your energy rather than restoring you. These are really important things to do, especially if you're living with PAH. And finally, movement, exercise. Some people, maybe exercise is not something that was ever really a part of their life or exciting part of their life, but movement really is medicine. And I think it's important to talk with your PH doctor or nurse practitioner about coming up with an exercise plan that will support your health. One way of doing it is, of course, to go to pulmonary rehabilitation. It's great. Like John said earlier, they give you oxygen, they help you, they work with you to progress based on what you're able to do and get you better over time at your pace. So I think movement is really important. So when we see people, this is part of our prescription as a PH physician. When I'm talking with my patients, it's of course a large component is on medical therapies, clinical trials, all that kind of stuff. But the nutrition, sleep, mind, movement are the key components that I think actually help people feel better in addition to medications. So what can you do? So back in 2012, when I had a bike accident and I was struggling for a long time after that and had a bit of a relapse from a head injury, my doctor, who's one of the world's best, Dr. Mickey Collins, turned to me and said, every day you wake up, you have to ask yourself, what is the one thing you can do to get better today? And that was like, okay, what is the one thing? So I just mentioned this whole laundry list, but what I leave you with is perhaps think about these components in your life. And what I find in my clinic is most people have one or two of them kind of dialed. Some people don't, but some people have some of these things kind of dialed in. So you don't have to work on those. And by the way, like count that a win. We believe in stacking up the W's, stacking up the wins. And so that's important to say to yourself, I'm good at this area of my life. what can I do? What is the one thing I could do in this other area, just one area to maybe work on or focus on to help myself feel better? And so you can talk to your healthcare team about resources like pulmonary rehabilitation. Ask your PH team, what can I do exercise wise? Can I go to pulmonary rehab? Nutrition coaching. Maybe you struggle with either sodium or fluid. That's an important part of what we deal with in pulmonary hypertension. Maybe you struggle with type 2 diabetes and you want to talk about putting that into remission with nutritional strategies. Like, talk to your doctors about doing that, or what resources there may be. Mental health, maybe seek therapy. Get engaged in your communities, whether it's a church community or other community. Establish those social connections, and sleep consultations. So of course, looking for sleep apnea and treating that, nocturnal hypoxemia and treating that, but also how can you improve your sleep and wake up feeling more well rested? So with that, I thank you, and I'm going to put on another hat here of Eric Borstein, who's going to talk with us next. Thank you.
Thank you, Dr. George. Appreciate that presentation. Very good information there. Okay, moving along, one more presentation. Last but not least, we have Eric Borstein, and he is a PAH patient who recently orchestrated a 5K walk from LA to San Diego back in September to support the efforts of Team PH and to raise awareness. His topic tonight will be Walking the Walk, Essential Pillars for Thriving on My Pulmonary Hypertension Journey. We'll let you tell all about your story. Go ahead, Eric. Thank you for being here tonight.
Thank you. Thank you all. And thank you for the opportunity. So yeah, my name is Eric Borstein, from Los Angeles, California, and I am a PAH patient. I was diagnosed idiopathic, and just want to tell you a little bit about my journey, my story, how I've gotten to where I am, and what I'm doing with it. So I like to start with a mantra. Live happy, breathe free, live life to its fullest. Never forget, but always learn from my mistakes. Don't race. Love every minute and enjoy every moment. Appreciate what I have and who I love. I deserve everything I've achieved and will continue to achieve. Go get it. Be happy. Be honest. Breathe free. This mantra I wrote day 10 of 16-day stay in the intensive care unit at Cedars-Sinai Medical Center here in Los Angeles. And it's something that helped guide me through the first days, months, through being diagnosed with PAH. The mantra still sits on the wall next to my bed. It's on a blanket that one of my daughters made me that I use, at night in the winter when we get cold. And it's something that I carry in my wallet with me every day and everywhere I go. And it's my lighthouse. But, the mantra I wrote was in the hospital, but, my journey started probably about 2 years prior. I was starting to show signs of what turned out to be PAH, swelling, shortness of breath, but I wasn't telling anybody. I was keeping it to myself. Later on, I learned that up to 75% of men don't go to the doctor. I didn't go to the doctor. I was afraid to find out what was wrong with me, but I learned I wasn't alone. There's 75% of us that don't go to the doctor when something's wrong. But in those probably 18 months, I was still active. I was mountain bike riding. I was playing paddle tennis. I was doing things, but I was struggling. I was struggling to breathe. As the months went on, it got harder and harder. And it got to the point where I couldn't go upstairs without, going into the closet and feeling like I was suffocating. So, those patients living with PAH and PH know what that feels like. And I was doing it alone. I'm married. I have children. But I wasn't sharing it with anybody. I wasn't sharing it with my friends. I wasn't sharing it with my family. I was truly hiding. I was going to the office more. And it was scary. It was really scary. So it was September 21st. It was in the morning. I was at home. I was in the office, and I wasn't feeling well. And it felt a little different than it normally did. I was down in my home office and I decided I'd go back to bed, and in a couple of days I'd feel better. And so I walked upstairs, and when I got to the top of the stairs, everything closed in. And I took 30 steps to my bed. It was the longest steps of my life. It was the most painful steps of my life. Sat down, stood back up, and went face down in the bedroom. And woke up about 25 to 30 minutes later with the paramedics in the bedroom. And it turns out that I was dying in the bedroom. I was put into the ambulance, and I remember the doors closing in the ambulance. And I remember looking up at the sky and saying, thank goodness, I don't have to hide anymore. I'm going to get help, and I'm going to get better. And so I was taken to the hospital. I was stabilized, and I was put on a pump with some very hard medications. And I remember in those first couple days after being stabilized, I sat there in bed, tears rolling down my face. My wife was there. It was during COVID, so she was the only one allowed to be there. Tears rolling down her face. And I remember holding her hand and saying, I'm going to beat this. I didn't know what that meant. I didn't know what that path meant. I just was resolute. Day one, I was going to beat this disease. It turns out I was diagnosed, I had severe right heart failure, and I was diagnosed with pulmonary arterial hypertension. I'm adopted, so I don't have any real genetic history. 51 years old, so at the time I was 47, and things back then were different than they are now. Records aren't as readily available. And so I was diagnosed idiopathic. I was in the hospital. I didn't know this. Nobody had heard of PAH before. Everybody, behind the scenes was trying to figure out, scramble, what is PAH? And I didn't realize this, but they were telling my wife they didn't know I'd leave the hospital. So in those first couple days, I started walking, 1 step, 2 steps, 1 trip down the hall. I ended up walking day, night. Any chance I got, I would just get out of bed and try to walk. And I learned that walking started helping with the side effects of the medication that I was on. The medication, for all of you that are on PAH medications, know it is really difficult. It's painful. And especially when you first go on them, it's absolutely brutal. And so I learned, the walking helped. I got stable enough where they sent me home, and they told my wife, unbeknownst to me, that I had 3 to 6 months to live. They told my wife, bring him home, make him comfortable, let him live his life, but just let him relax. So I went home, and the walking continued. 1 block turned into 2 blocks, turned into 3 blocks, turned into a mile. Eventually I started what I call my long walk Fridays, where I go out and I would walk 7 miles, 8 miles, 9 miles. And I started distancing myself from that initial diagnosis. Originally, they told me I would never get off the pump. But after a year, my right ventricle made almost a full recovery, and I was taken off the pump and I was put on oral medications. So the walking was helping. The exercise was helping. Getting outside was helping. And so the other thing that I learned with walking was it helped with the psychological battle. The psychological battle for a patient living with a terminal disease is definitely real. Not knowing what the future will bring, living with this terminal disease, it defines your future differently than somebody not living with one. And so, that mental psychological battle helped get me through the medicines, but it also it helped clear my head. And it was kind of this mix of exercise and mental health. And the walking just puts a smile on my face. It did back then, it does today. So the time went on, and my miles increased, and people started seeing me around the neighborhood. They would see me once, twice, 3 times a day. I was nicknamed the walking guy. I still am nicknamed the walking guy. in calendar years 2022 and 2023, I walked over 5,000 miles each year. By the end of this year, I'm on pace to walk over 15,000 miles in 3 years. I was actually recognized in Mykonos, Greece last summer from a mom and a daughter who are our neighbors. They didn't know me, but they recognized me, and they asked if I was, from Los Angeles. I said yes. They asked if I was from Brentwood, California. They said yes. And the mom grabs the daughter by the arm and says, "Oh my goodness, it's the walking guy." And so, the other kind of big component of my recovery early on was what I call my village. You can't go through living with PAH or PH or any terminal disease alone. It's hard enough living with this disease just in general, but doing it alone, like Dr. George, like Patty said earlier, we are social creatures, and that village and that support has been so critical in my recovery. It started day one when I was in the ICU. I had a family member drive over 120 miles just to race to be in the emergency room with me. I had friends there when I first got home. It was back in 2020. So again, it was during COVID. People were being careful, but they wanted to come spend time with me, and I wanted to spend time with them. And that still continues today. I have friends that check in on me, and I talk to friends, and I express my feelings. And, even to the point where when we go out to dinner, I will have friends advocate for me and make sure that there's no salt on my steak or there's no sodium in my food, because I'm on a strict nutritional diet. So that village is super important. And, the most important people to me are my kids and my wife, and they're my biggest supporters. They're who I rely on most when I'm having the worst days. And so that part of my recovery is just so important. And I call that my village. And so, it was a recent Thursday conversation that I was having with my psychologist, who I talk to once a week. And he pointed out that my life is kind of in two chapters. One chapter is what I'll call my journey from diagnosis to today. And the other second chapter is me being able to pass along this message of hope, and my story and what I'm doing today. And people ask themselves, why are you here? Why are you here on this earth? And I truly believe that day when I didn't die, that I was given a second chance to tell my story and to pass along this message of hope and to help those living with PH and PAH who need it most. And so, it was as I distanced myself from that hospitalization stay that I was talking to my family about wanting to raise awareness for this very rare disease that most people haven't even heard of. And so I was back at National Jewish Health meeting with some doctors, and somebody said, "You have to meet Dr. Patty George. She's part of this nonprofit called Team Phenomenal Hope, and they're promoting exercise as a means of wellness for patients living with PH." And I thought, well, wow, this is something that I do, and this is something that's gotten me to this point. So unfortunately, Patty wasn't there that day. We ended up connecting and talking, and Patty, as you could tell, her just enthusiasm is infectious. And I just wanted to learn more, and I wanted to be a part of this organization called Team Phenomenal Hope. And so it was probably a year prior to meeting Patty that I started, putting these ideas together of wanting to do a fundraiser, wanting to raise awareness for this very rare disease. And around that time, my daughter, I've got 3 children. My oldest daughter is 17, and she came up to me and she said, "Dad, I want to do an event to raise awareness for this very rare disease." And I said, "Great." And, I'd been kicking it around, and that was kind of the kick in the pants that I needed to kind of get this going. And so I thought, well, what better way to raise awareness for this rare disease then walk. The walking guy, why not walk? So we started kind of brainstorming and putting this stuff together. And that's where Where is EB was born. There's some debate in our house about how it was named Where is EB. My nickname is EB. I say that, friends and family will ask, where's EB today? Where's he walking today? And my wife and kids will say, no, it's more like, where's Waldo? Instead of where's Waldo, where's EB? So we started brainstorming, and so we put together the idea of doing a 5K and a walk and a fundraiser. And then I said, well, let's go big. Let's do something else. And so I decided that I was going to walk from Los Angeles to San Diego to raise awareness. So we put this fundraiser together, and initially it was going to be friends and family. It ended up being, we had over 300 people on September 21st or September 22nd in Santa Monica for the first annual Where is EB. And the event culminated with me heading out and walking 202 miles in 6.5 days from LA to San Diego to raise money and awareness for pulmonary hypertension and pulmonary arterial hypertension on behalf of Team Phenomenal Hope. It was totally grassroots, and we ended up raising over $190,000 this first year, with 100% of the proceeds going to Team Phenomenal Hope. And we're thrilled to announce we're going to end up doing it again next year. And so, most people living with this disease just aren't as lucky as I am, or should I say they're not as fortunate as I am. I'm so fortunate that I have this amazing village, and I've got the most amazing doctors, and I haven't done this alone. And I'm fortunate that my body reacted the way it did really early on to both the medication and to the exercise and to the diet. A lot of people aren't that fortunate. Most people aren't as fortunate as I am. And it's for that reason why I wanted to be involved with Team Phenomenal Hope, because they're helping those that need it most. My story to this point has been one of successes, one of milestones, one of victories. And while my journey has been difficult and it's painful, and it's still painful, the side effects are real. The side effects are sometimes debilitating. There's some days that I just don't want to get out of bed, but I do. You always know you're living with this terminal disease. And if there's one thing that my journey demonstrates, it's the importance of not only the right medication and the right medical care, but it also stresses the importance of mental health, of nutrition, of exercise, and relying on your village. And all of those components are what I call my pie. Those are all pieces of my pie. And if it weren't for all of those pieces being put in place, I wouldn't be here to where I am today. And I will tell everybody, I will help anybody in relaying that message, because all of those pieces of that pie are just so important. And so, I'll end with one story that I got from the Where is EB walk. I was lucky enough and fortunate enough to have given access through Camp Pendleton. Another board member of Team Phenomenal Hope, Carl Hicks, worked on getting me access, and that walk through Camp Pendleton was the highlight of my week. And I was probably about halfway through the walk. I was alone, and a soldier came and interviewed me and put his hand on my shoulder, and he said, "Sir, may I ask you a question?" And I said, "Absolutely." And he said, "Are you a Christian?" And I said, "I'm not, but I can tell you that I was given a second chance of life to tell my story and to relay this message of hope." And he stops and he looks at me and he goes, "Sir, that is one of the deepest messages I've ever gotten, and it transcends all religion." And it's that story and it's that example to why I tell my story and why I'm doing what I'm doing, and why I will continue to fight every day for the rest of my life, not only for myself, but to raise money and awareness for this disease that most people haven't heard of, and most people and all people that have it struggle with, but has been just part of my life and what I've rededicated my life to. So thank you all for listening, and thank you for the opportunity for telling my story.
Thank you, Eric. Appreciate that. Phenomenal story, very inspirational. You are literally a walking miracle. And
thank you.
To find out more about Eric's story, whereiseb.org, you can visit. He has his own website. And so under our page, whereiseb.org. So thank you for your support and efforts here at Team PH. We greatly appreciate you. Okay.
Of course.
At this time, we ran over time a little bit here. So we do have some questions already have been answered in the chat. So we're gonna, if you have any other additional questions that you want to ask, you can email me and I will make sure that your questions get answered. My email address is Tonya@teamphenomenalhope.org. Tonya@phenomenalhope.org. So if you have any questions, you can send them to me if you didn't get them answered or put into the Q&A today. But we want to really, really thank each presenter today. You all have been phenomenal, and we greatly appreciate all your efforts, all of your support from me and the team here at Team PH. Thank you. We appreciate you, and we are so grateful for you. And this has been a great presentation tonight, very informative, and hope everyone has a great night and take care.